Good afternoon, TEAL community, and welcome to today's Facebook Live on genetics. My name is Alana Feuchter, and I am the Senior Manager for National Programs with NOCC. For the last several months, we have used this platform to bring you leaders in the medical community who have graciously shared their knowledge. This includes a genetic counselor who came to speak with us at the end of September during Hereditary Breast and Ovarian Cancer Week. Today, we will do a brief recap of what we learned in September, but then we will hear from a panel of 4 ovarian cancer survivors, each of whom has a genetic mutation. They'll share a bit about their diagnosis, how they received genetic testing, how it impacted treatment and other aspects of their lives, and how they shared the news with family. Then you will have the opportunity to ask questions. As a survivor myself, I find that hearing others' experiences brings me a sense of community. I hope you will find the same today. Now I am pleased to introduce our wonderful panel of speakers. Neat Gutenfelder, Katya Lezah, Liz Spoone, and Yvette Wiggins are our survivors. And I am joined today, gratefully, by Brenna Roscow, who is a genetic counselor with Myriad. I'm going to try to share my screen so we can show you, there we go. Oops, I think that worked. I'm sorry, folks. Let me share my screen. And then, let's see. Can you just shake your head if you can see this, the Myriad slideshow? Okay, perfect. Okay, great. So as I said, today is our Ask the Experts Genetic Testing Part 2. Okay, sorry, I'm new to a PC. I am a Mac person myself. There we go. It's ironic that today is actually Genetic Counselor Awareness Day. So for those who didn't know, there is a day for everything, and that is today. The discussion topics that I will share, or I will turn it over to Brenna for in a second, will be to discuss the differences between what a somatic tumor is versus a germline mutation. We'll talk a little bit about the prevalence of ovarian hereditary cancer, the rate of genetic testing, and the benefits of genetic testing. So I am going to turn this over now to our medical expert, Brenna.
Thank you guys for having me today. And it is very fortuitous that it's Genetic Counselor Awareness Day, and I think it's just meant to be. I am a hereditary cancer genetic counselor in my background, so this is something that's very near and dear to my heart. And of course, I work for Myriad Genetics, which offers hereditary cancer testing, both for what we call germline testing and somatic testing. I know last month, Shelley shared a little bit of the differences between these two with the entire group. But just to recap, there are 2 very distinct types of genetic testing available for women with ovarian cancer. The first type is what we call a somatic testing, or sometimes you will hear it called tumor testing. And that's basically where a sample of the actual cancer or metastases or something that has cancer cells is tested genetically to figure out what kind of fingerprint that particular type of cancer has. We like to say that all cancer is genetic, but not all cancer is hereditary. So everybody's cancer is 100% unique because it stems from unique genetic changes that just arise by chance. On the flip side, we do have what's called germline genetic testing, or sometimes you'll hear hereditary genetic testing. You might even hear just even BRCA testing, BRCA1 and 2. They're all the same thing. Basically, hereditary testing looks at the DNA makeup that you're born with and that you inherited from your mother and your father. And so those DNA changes that somebody inherits, it can be found in every single cell of a person's body. And usually that testing is either done from a saliva or a blood sample because the DNA from those samples is representative of the entire genetic makeup of that person. So go ahead and change the slide for me. Perfect. So why am I bringing this up? Well, I think it's important for every woman with ovarian cancer to realize that both types of testing are important, not only for you, but also for the family, and figuring out who might have an inherited risk for cancer. We know that about 48% of women with ovarian cancer will either have a BRCA1 or 2 mutation, and that could be something that was inherited or may only be contained within a person's cancer. And then the other, or women in that group of 48% may also have some other type of fingerprint in their cancer that makes them eligible for a drug called a PARP inhibitor. So by doing both the germline and somatic testing at some point right after diagnosis or during treatment, both of those things are very important to figure out, was this cancer inherited? Is there anything in my cancer that would be a good target for a PARP? So up to 24% of ovarian cancer may be hereditary. So again, those are the types of mutations that are inherited from a parent. The most common thing that we find are mutations in BRCA1 or BRCA2, and that's also known as hereditary breast and ovarian cancer syndrome. But there are many other genes that can cause a risk for ovarian cancer, including Lynch syndrome, and there are 5 different genes that are known to cause Lynch syndrome. And then a smattering of other things that are much more rare, but still a potential cause for ovarian cancer. That includes STK11, BRIP1, RAD51C, and RAD51D, TP53, and PALB2. Every single woman who is diagnosed with ovarian cancer meets guidelines for genetic testing. That guidance has been around for quite a while, but it's also important not only to know that genetic testing is available for all women who are diagnosed, but it's also available for family members. So if you have sisters, nieces, even brothers who want to go and have genetic testing as a result of the family history of cancer, they should be able to have that happen because it's part of our national guidelines for genetic testing. And most insurance companies have some sort of guidance on how to pay for that genetic testing as well. All right, I think we have one more slide to go through. So why prioritize testing? So the main thing is that it can provide critical insight into your cancer diagnosis. In some cases, it can identify the cause of cancer. And I know that's always a big question is what has caused a person's cancer? Why did it happen? And sometimes genetic testing can help answer that question. It may help to identify treatment options, including new FDA-approved targeted therapies, such as the PARP inhibitors I just mentioned. Sometimes it can make patients eligible for clinical trials. And it also helps, of course, identify family members who may be at risk for cancer. On the flip side, it can help beyond just the diagnosis of ovarian cancer. It can help inform you whether you are at risk for any other types of cancer. It could be breast cancer, colon cancer, a bunch of different things these genes can cause. It can help you form a plan with your healthcare provider on how to take preventative steps against those cancer risks. And again, it can help identify family members who may be at elevated risk. And really, what I would love to see in the world of genetic testing is that we're preventing cancer from happening altogether. So by identifying those family members at risk, hopefully we are decreasing the rate of cancer overall. So I'm going to stop there. Thank you so much for letting me share. Oh, Alana, you're still muted.
Thank you. I'm going to stop sharing my screen. Now, I guess we will go into the stories, and each of our panelists will share a little bit about themselves. And we will start with Liz.
Hi, good afternoon. Thank you for giving me the opportunity to tell my story. My story starts 5 years ago in July of 2015. I was coming back actually from a wedding, and I was having all kinds of issues in terms of eating and digestive, and I was having some bloating. So I went to the doctor, and unfortunately, I think our doctors need to learn more about what are the symptoms of ovarian cancer, because I was kind of poo-pooed and told to take some probiotics and you'll be fine. And they didn't hear anything, didn't see anything. So I needed to move on. So 2 weeks later, I'm practically eating, 10 probiotic pills a day. And my stomach is sticking out to where I look like I'm 9 months pregnant. So I went to urgent care, and from urgent care, I was sent straight to Fair Oaks Hospital, which is the local hospital in our area. And in the emergency room, they did some diagnostic tests and came back and told me that they were rushing me to Fairfax Hospital, which is the bigger hospital in this area, and that I had a large mass on my ovaries. So I had the surgery. I had some problems after surgery. I ended up being in the hospital for about 2 weeks. I got out and started my 6 rounds of chemo. And about halfway through my chemotherapy, I talked to my oncologist. Well, don't you think I need genetic testing to see where I'm at with this? Well, what would have caused it? And I was a little concerned because at that point they had told me I had a very aggressive form of ovarian cancer. So I wanted to kind of get to the issues, find out what was really causing all this. Went and did the genetic testing, which is really very simple. And I can't stress that enough. It is spitting in a cup. You don't have to give blood. There's nothing painful about it. Just get your spit all organized and spit it in a cup. And it came back that I had Lynch syndrome. Well, I wasn't really familiar with that. So I wanted to give you a brief synopsis that it's something that's associated with colon cancer, biliary tract cancers, ovarian cancer, and endometrial cancer. Well, my dad had died of cancer, a bile duct cancer. So now the question is, I've got to tell my daughter that she needs to be tested. And you have all this guilt built up in you because maybe you've passed this on, you don't know. And then when I tell my daughter I want her to get tested, the question is, if she gets tested, will that affect her with her health insurance? Will that come back and be a problem because she's got some kind of, pre-genetic syndrome? It did come back that she had Lynch syndrome. So then we got on Ancestry, and it was just amazing to go back and look at our genetic makeup through my father's side of the family. His mother had died when he was very young, and he wasn't really that familiar with what she had died of. I think he was 5 years old at the time. Well, it turned out she had died of colon cancer. Several of her brothers and sisters died of colon cancer, and their mother had died of colon cancer. So I could follow the track straight down through Ancestry and see where the Lynch syndrome originated from and how I had passed it on to my daughter. And it is very distressing to know that, you've given this to a family member. But then we decided after much discussion that having knowledge is more important than not having knowledge. So now she's very good about getting her colonoscopies. We've talked about, the possibility of after she's done having her children, having the full hysterectomy, just to make sure that, she doesn't have any future problems with ovarian cancer, because it's, not anything I would wish upon anybody. So that's my story. And I hope if anybody has questions about Lynch syndrome, they'll send us a message. Thank you for this opportunity.
Thank you, Liz, for sharing and telling your story. I think that's comforting for other people. Next, I'd like to invite Yvette to share her history with ovarian cancer and genetic testing.
Okay, again, I thank you as well for allowing me to come and share my journey with all of you. My journey started in 2017. It was in February of 2017. I was not feeling well, and I was on a work trip, and all of a sudden I couldn't eat. I was getting full very fast, and I just wasn't feeling well, and my stomach was swollen. I don't remember how many months I looked, but it was quite large. When I came back home, my husband and I decided I couldn't shake it, that we should go to the hospital. We went to the hospital, to the emergency room, and everything, all my blood tests and everything they was testing kept coming back negative. But I had a really good doctor who kept saying, but something's not right. Something's not right. Do you mind if we keep testing? Can we keep testing? And of course, I wanted to feel better. So it was like, of course, keep testing, keep testing. And so finally, she came back and she said, I have some unfortunate news for you. You have ovarian cancer and it seems to be advanced. And she recommended that I see a gynecological oncologist as soon as possible, and recommended me one. So soon thereafter, I scheduled an appointment. I went in, I met with them. And he ran all the necessary tests, and come to find out I did. I had a CA-125 at the time of really, really high, like over 8,000, 9,000, something of that nature. And I was going to need surgery. And so what he decided was, after they did the scan and saw the size of the tumor, that I should go undergo something they call neoadjuvant chemotherapy, which, if you don't know, is where they give you like 3 doses of the chemotherapy ahead of time, and with the hopes of reducing the size of the tumor in order to have a more successful surgery. So he did that, gave me the chemo, my CA-125, everything started reducing. The size of the mass started reduced. I had the surgery. They took it out, and they tested it and came out to be stage 3. What they thought was 3C, but after they had the whole tumor, it came out to be 3A. But during that time, they recommended that I take genetic testing, have genetic testing, because no one in my family had it, and they just was curious, and it was available, as Brenna said, for people to do. So in August, late July, August of that year, I had genetic testing done. They tested about 42 genes. They came back. It was very easy. Like she said, it was just spitting in a bottle. They sent it off, and they came back, and it was discovered that I had RAD51D, which is closely associated with, I think, people, 10 to 20% of people who have that gene end up with ovarian cancer or something of that nature. So that sort of explained where it came from. Part of it was my family was, I didn't have daughters, I have sons, but I have nieces. And so it was offered to my brothers and, my father, so they, they could try to determine where I got it from. My brothers all came back clear, as well as my father. Unfortunately, my mom had passed, so she wasn't able to be tested, but we attributed it to a gene I inherited from my mom. So after that, and I had this, the surgery, genetic testing, and then I had the surgery, which was a total hysterectomy, bilateral oophorectomy, and then they had 3 more chemotherapy treatments, and I was doing pretty well. After that, in about November of 2018, I started feeling unwell again, went to the doctor. They ran some tests, and come to find out it had metastasized to my brain. And therefore I had, in December of 2018, I had to undergo a craniotomy and some radiation treatment. So it was on my right perineal lobe. They took it out. It was 6 centimeters. I had 5 radiation treatments, and they went on. Doing 3-month MRIs and things of that nature. And I had had 1 more radiation treatment later on down the line. And since that time, I've been doing pretty good. But we can't stress enough that when you're not feeling well, you have to be your own advocate with your doctors, because they're right. They don't know you, you know your body. And it's really important that if you think something is wrong, that you go to the hospital, you go to the emergency room, and you stress to your doctor to test for different things, because the earlier they can find out about these things, the more success that you have. Treatments are great now. And with the RAD51D, unlike most people hear about BRCA, the RAD51D is also very sensitive to the treatment. So I had a treatment of carbotaxol and I responded extremely well. And within like 2 or 3 treatments, my CA125 had come back into the normal levels, and I've maintained that since that time. So I appreciate the opportunity to share my story and my journey. We're striving and thriving, and look forward to any questions that you may have.
Awesome. Thank you, Yvette. I'm glad you're doing so well. Next up, I'd like to introduce Nee Guttenfelder, who will tell you a little bit about her experience. Welcome.
Thank you for the opportunity. I'm happy to be here today. Yeah, my name is Nee Guttenfelder. My story actually started in 2007 when I was diagnosed with cervical cancer, stage 3B, and I was referred to a gynecologic oncologist where my treatment entailed a radical hysterectomy with my ovaries clipped up in hopes that it would be spared from radiation. Unfortunately, that didn't work. I did go into early menopause after 25 rounds of external radiation and then 2 treatments of internal radiation. And I also completed 5 rounds of cisplatin chemotherapy. After that, I was cancer-free, closely monitored with pap smears, as well as annual mammograms due to my family history. My sister had breast cancer at 33. My mom had breast cancer, and I had an aunt who passed away from breast cancer. So the topic of genetic testing was brought up by my sister's doctor, as well as my mom and my aunts, I believe. But my family members did not want to get tested. There was anxiety that, we may open up this whole Pandora's box within our family history. We were all already getting annual mammograms, and then also possible discrimination with either health insurance, maybe even employment somewhere down the road. But I really wanted to know. And when I brought it up with my doctors, they said that really it should be the individual, because the cervical cancer is not hereditary, and I knew that. But it was the individuals with breast cancer that needed to get tested. But eventually in 2015, my gynecologic oncologist did agree to order genetic testing for me, and it was a simple blood test. And mine came back that I had 2 genes of unknown significance. And they said, there's nothing to worry about. If and when there are updates to the database, you would be notified. So then fast forward to October of 2017, I was at a work conference. My gynecologist called a couple months before my routine visit. And he said, one of my genes has been reclassified to BRCA1, and that I needed to come in the following week to discuss increased surveillance. Well, the very next day, I was at another conference where I ate a turkey sandwich. My husband and I had gone vegan for a healthier lifestyle, and I was so hungry I ate this meat sandwich, and then my stomach was in painful knots. I thought I had food poisoning because I had diarrhea and vomiting for over 4 hours, and we eventually went to the ER. They ran all sorts of tests. Everything was normal, except I had colitis, which there was some blood in my stool, and everything was normal. So then they proceeded to do a CT scan, and that came back that I had several masses in my omentum, abdominal area, and I was told that it was my cervical cancer that was back. A needle biopsy was done, and it came back as metastatic cervical cancer, but they couldn't rule out that it wasn't ovarian. And my gynecologist was concerned because he said my cervical cancer isn't supposed to come back after all these years. So during that time, it was very volatile. I was constantly in the hospital. My bowels were paralyzed for 3 weeks. And then once that resolved, I was back in the hospital. Then there was a blockage where the tumor was wrapped around my sigmoid colon, and I needed to have emergency colostomy surgery or go home on hospice. So I opted for the surgery. And during that procedure, a golf ball sized biopsy was taken, confirming that I had stage 3C ovarian or primary peritoneal cancer. So it was indeed a second gynecologic cancer that was unrelated to my first one. But because I had the first cancer, it complicated my diagnosis because I did have symptoms of urinary frequency. I had some weight gain, which I thought it was from early menopause, but I had been in menopause for over 10 years. And So my treatment early on kind of masked my symptoms. So with the ovarian cancer, my first line treatment, I completed 10 rounds of carboplatin, Taxol, and Avastin. I did have my debulking surgery in the middle of that, and I was able to get my colostomy reversed at the end of that. After my frontline treatment, my oncologist put me on a PARP inhibitor called olaparib or Lynparza. Because I have the BRCA gene, it was thought that, I would respond well to it, have a good response. Unfortunately, the PARP inhibitor did not work for me. I was on it for about a year, and during that time, I was in and out of the hospital about 6 times for partial bowel obstructions. During the last 4 months of the year, my CA125 tumor marker was slowly increasing, more bowel obstructions. So January of this year, a PET scan was done showing that I had several masses. And so I was back on IV chemo. I started carbo and Doxil. During the second treatment, I had a reaction to carbo, so then I was just on Doxil. And June of this year, we weren't sure if the Doxil was working because some of the tumors had grown, some of them had shrunk. And so at that point, since I was tolerating the Doxil well, we decided to continue a little bit longer while I looked into clinical trials. So we spent a couple months looking into clinical trials and decided it wasn't the right path for me because I had a prior cancer. I didn't qualify for a number of the phase 2 and 3 trials that had more of a track record. And I wasn't keen on the idea of the phase 1 because those are more geared towards determining dosage and side effects, whereas I want tumor response. And so I decided to stick with standard treatment. In the last month and a half, I was admitted twice in the hospital for bowel obstructions, and there was another new mass that showed up on a CT scan. So we changed my treatment. So now I'm on weekly Taxol. And my oncologist he has informed me that I will be on treatment indefinitely. Right now, it's just a balance of the toxicity that I can handle and my quality of life. So it's balancing the two. And I did want to circle back to the genetic testing. Once I was diagnosed with ovarian cancer, 3 of my sisters got tested. 2 of them do not have, the BRCA gene. One of them does have the BRCA gene. It happened to be my sister who had breast cancer. And I have 2 brothers who have not been tested yet. We know that they are at possibly higher risk for prostate cancer. One is in the military. So, but they're still deciding. So now there's more open discussion about it. And, so we just, so that's where I'm at today. I think the biggest thing that has helped me is, I have a huge support system with lots of family and friends who have been extremely supportive. And they actually, 2 of my sisters and my husband helped me with starting an organization called Speak Gyno, where we can offer resources to the community. A big piece is our podcast, where we share their survivor stories and just to offer encouragement and inspiration, because I know that has really helped me through my journey. So thank you so much for this.
Thank you, Nee. And I think what you just said is going to inspire a whole nother round of ovarian cancer survivors as well. So thank you for being such a fighter and for sharing your story today. Our last panelist I would like to introduce is Katya Lezah, and I'll let her share her story. Oh, you're still on mute. Oh, no. There should be a mute button at the bottom left one. There we go. You're good now.
Hi, everybody. First, I just want to say I'm so inspired by the other panelists, and my heart goes out to all that you all have been through. But I also think that for all of you who are watching and who are in the thick of your own fights, I think no one would look at any one of us and know all that we've been through and that we are all survivors. And I think that should really speak to you that full, vibrant lives are available to you during treatment, post-treatment. And I hope that if, one of your takeaways is just to know that you can get through this. And, obviously we've all been through a lot, but there's good times ahead. So I'm a 2-time ovarian cancer survivor. I was first diagnosed in 2011. Unlike the other panelists who showed pretty typical symptoms associated with ovarian cancer, but as they've kind of reflected, those often go misdiagnosed or undiagnosed by not just women, but by their medical professionals as well, because they're very typical of just middle-aged, women, and kind of what happens when you hit menopausal age. But for me, I actually had rectal pain. And I was just lucky that I went to see my OBGYN because I was kind of a bad patient. I was 45 years old, and that was my primary. And he did an ultrasound and saw that one of my ovaries had twisted and descended and was rubbing against my rectum. Cancer didn't come up. I wasn't worried because he wasn't worried. We actually had a good laugh because he told me he thought it was due to excessive sex. And I was like, what's behind door number 2? Like, I was told him my husband would be astonished to learn that that's what we're engaging in. But he took it out. And luckily for me, we live in a country where when you remove a body part, it gets sent off for analysis. And so that's where cancer came up. My ovary went off to the pathologist, and the pathology came back with ovarian cancer. So I got that call that, it sounds like we've all been on the receiving end of, that began with the words, I don't know how to tell you this. And, as all of you know, who have received that kind of call, that, just kind of instantly creates a new normal, right? It's just the demarcation between life as you knew it and everything that follows. And I came back and was also handed off to a gyn-onc. And this is 2011. And the importance of that date with respect to hereditary cancer testing is that I think I have the earliest diagnosis of everybody out here. That was before Angelina Jolie kind of was on the cover of Time magazine and People magazine, and was on, wrote a New York Times op-ed about the fact that her mother and grandmother had died of ovarian cancer. And she learned that was because of the BRCA1 mutation in her family, which is the one thing I have in common with Angelina Jolie. And so that's really what started the national dialogue about hereditary cancer testing and the BRCA mutation. I think, there were certainly, Myriad had been testing for it long before then, but I think that's really when it got into kind of the national consciousness, and it was something that was known among laypersons and patients. So because mine was several years before then, I had never heard of it. Luckily, the oncologist was on the ball, and he did know about it. He walked in the room, and before he had even said hello to me or shaken my hand or introduced himself, he just walked in the room and he goes, "Are you Jewish?" And now, mind you, I had no context for this, right? So I'm like formulating my answer of like, well, I wasn't raised Jewish, but I know a good bagel and lox when I see one, and I married a Jew, and the kids are a work in progress. He didn't want to know any of that, right? He wanted to know, are you of Eastern European Ashkenazi Jewish lineage? Because 1 in 40 Ashkenazi Jews carries the BRCA mutation as compared to 1 in 400 in the general population. And the reason he thought it was likely that I had the BRCA mutation is that I was there to see him because I had ovarian cancer. So as we've established, ovarian cancer is its own red flag. You don't need to meet any other criteria. If you don't even have to be the affected patient. So for all of us, all of our first and secondary relatives qualify for genetic testing just based on the fact that we have had ovarian cancer. I also was 45 years old, which is another red flag. Turns out it wasn't young for purposes of my sex life, but for cancer, that is young, right? So these cancers under the age of 50 are another red flag. So rare cancers, multiple cancers on one side of the family, or young cancers. And I, also had the Ashkenazi Jewish lineage. So I was just lit up crying out for genetic testing. But one thing I've learned is that we have to be our own best advocates, because as some of these stories have highlighted, just because of the fact that you definitely qualify, insurance would absolutely pay for it, it is warranted in your case, does not mean that your medical team is automatically going to do it. So we as patients need to be our own best advocates to say, I need this, I want this, and I deserve this. And the reasons for that are multiple. I mean, for me, the immediate kind of benefit was that it answered the inevitable why me, which I think is a pretty natural go-to when you have cancer. And for me, it was really helpful to have a scientific explanation for how and why my cancer had come about. That it wasn't cosmic bad luck, or as my mom thought, my Diet Coke consumption, but that there was actually a scientific reason. And as much as that helped me emotionally, I also instantly got that was definitely going to help my medical team, that knowing the source of the cancer would allow them to better treat it. And a lot of these advances in cancer care, these personalized, targeted therapies, stem from knowing the source of the cancer. I also learned that I would respond better to both the chemo regimen that I was on, which was Taxol and cisplatin, and the way that chemo was administered, which was directly to the affected area through a peritoneal port in my abdomen because of my mutation. I don't really get the science of it. I always tell people, don't push me too hard on this, but the way it was kind of dumbed down for me is that the mutation is a breakdown in the repair pathway. So the cells can't repair themselves as well when they're blasted with chemotherapy. I didn't really care why. I just cared that, right? I mean, as we all know, hope is such an intangible but crucial piece of the puzzle in cancer care and treatment. And for me, knowing that everything that was done to me, and I was really beat up, you know, not nearly to the extent that some of your stories have indicated, but I mean, I had a full hysterectomy followed by 5 months of grueling chemotherapy. And knowing that that wasn't just going to buy me a little extra time, but that because of my mutation, I could actually, you know, survive this thing, that allowed me to withstand it all. So that was huge. It also, as some of the stories have alluded to, the importance of knowing whether your cancer stems from a mutation is that cancer may not be the only cancer you need to be worried about. For BRCA1, it turns out that ovarian cancer was the less likely of the two major cancers associated with my mutation. I had an 87% lifetime risk of getting breast cancer. I didn't like those odds. I don't know anyone who would, but once you've lost the cancer lottery, I think we can all say you no longer kind of feel, you know, as impervious to it, right? So I wanted my breasts removed immediately. I know for some women, it's an agonizing decision. For me, it was a no-brainer. I was like, now you might try to kill me, bye-bye. And so I chose to have a prophylactic double mastectomy that was fully paid for because of my mutation. And I think that's a practical plus that's sometimes lost on patients. Your mutation isn't just going to let you know your odds of getting certain cancers. And sometimes those cancers are hidden in your family history, right? And so it's only through the mutation that you're going to know what your odds are for some of these cancer risks. It's also going to let you know the medical management that will help you reduce or sometimes outright eliminate that risk. And it's going to make it much more likely that whatever you choose to do to bring down that risk is going to be covered because of the mutation. It quantifies the risk, speaks the language that the insurance companies can understand, so that as expensive as my prophylactic mastectomy was, it was a lot less expensive than paying to treat me for cancer, a cancer that I was very likely to get. And I just appreciated for my peace of mind and my family's peace of mind that I didn't have to say, this is what I want to do, but this is what I can afford. My mutation put every option on the table. I have two more positives. Do I have time, Alana? Okay. With respect to the PARP inhibitors, you know, when my cancer came back, PARP inhibitors were not yet FDA approved. This was at the end of 2013. And so I was going to have to undergo the logistical, financial, and emotional upheaval of being treated in a clinical trial away from home. And, you know, the only thing worse than hearing you have cancer is hearing you have cancer again. And the only thing worse than that is hearing you have to leave home to be treated. Luckily, the surgery took care of all visible signs of the cancer. It recurred on my spleen and I had a splenectomy. And so I didn't need the PARP inhibitors, but now they are FDA approved. And so I can live my life without being consumed with fear and worry about what if my cancer comes back. It won't be fun, but if it does come back, I can be treated at home in pill form, which is a huge gift to me because it turns out the only dainty part of my body is my veins and we could never start a line on me. So knowing that like I don't have to get chemo intravenously and that it's available where I live is huge. And it lets me kind of put my cancer on the back burner and live my life. And those PARP inhibitors were developed because of genetic testing. So that's another gift that, you know, the same expertise that goes into finding these mutations, and they're constantly expanding. Myriad now has 35 different mutations on the panel that it tests for. It also is being used to partner with the fine folks who are trying to find protocols and treatments and hopefully one day a cure. And then the final positive, and we've all alluded to this, is that this is a gift I am giving my kids. And unlike some of you, I truly never had a moment of guilt about this. I believe that this is a gift I'm giving them. I'm giving them the power of knowledge. I've had over 10 major surgeries. I've had a dozen overnight hospitalizations, the removal of multiple body parts, hair loss, needle pricks, you name it. I don't know what parent wouldn't want to spare her children that. And I have the means of doing that. I took one for the team so that they don't have to go through what I went through. I used to speak about this theoretically, but since a couple years ago, I do have one of my 3 kids, my 24-year-old daughter, Hannah, has tested positive. And I will keep it real with you, like it was a punch to the gut. And I remember thinking that she should not have to be dealing with cancer at her age. But here's the reality. Any of our kids, any of our loved ones are already dealing with cancer. They have seen us suffer. They have seen what we've gone through. I had cancer twice in the time that Hannah was in high school. It consumed her teenage years. It was already on her radar. So what the mutation did was it got to change the narrative and let her feel empowered and be in charge instead of waiting and worrying for that other shoe to drop. And, you know, Hannah, when she learned that she was positive, her reaction was, well, now I really got to get me a boyfriend. And I was like, okay, yes, among other things, you'll want to start a family sooner rather than later. But even on that front, there are so many options. She can freeze her eggs. She can even figure out which ones have the mutation. And for me, what it came down to is that if I'm going to have something in common with her, I would so much rather that it be my mutation than that it be my cancer. So that's how I look at it. And the only scenario in which I would feel guilty is if one of my kids got a cancer that we could have predicted and prevented. So to me, for all that we've gone through, or for those of us who have lost loved ones to cancer, this is a chance for something positive to come out of that negative. It's the silver lining of those losses. And I think all of us would want something, you know, others to benefit from what we went through and to be able to help them kind of circumvent the big C. Right? So that's kind of how I ultimately feel about it. And it's not just my kids who benefit, but my siblings, my cousins. I have a cousin who, because of me, got tested, and he learned that he is BRCA1 and BRCA2 positive because he got it from each of his parents, and his 25-year-old daughter inherited both mutations. And to me, that just gave me goosebumps that I saved her life. You know, because of what I went through, my dad, who gave me this mutation, was one of 3 brothers. So there were no women on that side of the family to manifest the cancers that would have given us a heads up. We would never have known about these cancer risks, but for my getting cancer and knowing about this mutation. But since then, we all have the heads up and are able to avoid the big C altogether. So I hope what comes through is my passion about this. I feel so lucky that I was tested, but I feel equally strongly that it shouldn't be a matter of luck. It shouldn't be a function of where you live or who you go to see, or if you happen to have a doctor who's on the ball or isn't. And so we can all partner together to make sure that our loved ones are their own advocates, and that we spread the word about this both to the medical profession and to patients, to make sure that for those for whom it's warranted, it is absolutely life-saving and they deserve to be tested. Thank you.
Awesome. Thank you for sharing that, Katya, and for the positive attitude, because I think, you know, that's you're giving your daughter a gift, but also all of us a gift in talking about it. Before I move on to some questions, because I do see that we have a few, I just want to highlight a couple of key points that came through here that I want people to be cognizant of. And we've already addressed in the previous genetic Facebook Live, but one is 2 of the women here received their genetic mutation from their father. So it is not just something handed down from on the female side. So that's really important to think of. Another one is that every woman who has ovarian cancer is eligible for genetic testing. And as Brianna showed on the slide, maybe best case scenario, 25% of ovarian cancer patients right now are getting genetic testing. So we really should be getting at 100%. Yvette actually was an example of somebody who has no family history and yet still had a mutation. So I don't want people to say, oh, my ovarian cancer came and I don't have any family history. You still might have a mutation because it could have skipped your older, relatives might have just been luckier in not getting it. So these are some key points that I think we want you to have as takeaways. The other one I wanted was something that Nee brought up, which was the mutation of unknown significance. And so sometimes when you do genetic testing, that will come out, that they can't really decide if it's meaningful or not meaningful, but that information is stored, and as more and more women are getting tested and we can see some more patterns, we will be able to identify that maybe, yes, that is indeed a true mutation that other women might be able to be tested for in the future. So those are the key takeaways that I have. I hope that you all had more, but I'd like to go to some of our questions. We had a lot of people watching, a lot of right-ons. Thank you for sharings. Yes, somebody asked if this will be available for viewing afterwards. It will be on our Facebook page and also on our YouTube page. Let me go through here just a second. So many people. Thank you, all of you who are watching this. Thank you from Elizabeth, who said thank you. Wow, lots of names. Okay, one of the questions we have here, whoops, sorry, is I have prominent cancer on both sides of my family, but negative for cancer gene markers. She had ovarian in 2016, endometrial in 2016, and now breast cancer in 2020. I'm going to throw this to you, Brianna, because this is your expertise. What would you suggest to Robin, who has had all of this, but yet no genetic gene markers?
So I wish I could tell you that, you know, well, what I want to say is you're not alone. In my clinical practice, the majority of people who came to see me tested negative for gene mutations. And I didn't see people just off the street. I was only getting referred patients with a significant family history of cancer. It sounds like you yourself and your family fall on the even more significant side of what might be considered average. My question to you, though, and maybe your question to your healthcare provider would be, how long ago were you tested? What genes were analyzed? What laboratory did it? And is there anything else better out there? Because genetic testing, when you have it done, it's really like taking a snapshot in time. We can only test you for the things that we know about in that moment or at that particular time in history. And there may actually be some advancement that has come along since you've had your testing where we could find something now that we couldn't back then. And that might also be true in the future. So it's just, for a lot of people who go through the genetic testing process, it's not the last time that it needs to be discussed. And it should be something that you bring up again with your doctor or with a genetic counselor. Just keep asking those questions. And hopefully science will catch up with whatever seems to be happening with you and your family.
That was helpful. Here is a question from Zuzel. It says, thank you for sharing. We have some cases of cancer in our family. However, the only loss we have had is my mom. She passed in April, 2 weeks after being diagnosed with stage 4 ovarian cancer. She had no symptoms that would have alarmed anyone. My sister and I have had genetic testing, and she's choosing to have a proactive oophorectomy. So I think she's just trying to share that. There's not a real question. But yes, that is the recommendation if you have a genetic mutation after you reach a certain age, to have your ovaries removed prophylactically and fallopian.
The other thing I want to bring up is that even for people who don't have a known mutation, we do know that when you have a family history of ovarian cancer, your risk does increase. So if you have a mother or a sister, which would be considered a first-degree relative with ovarian cancer, your personal risk of ovarian cancer doubles. Now, the average risk is pretty low, right? So doubling the average is still pretty low. But every time you have more and more family members who have that history, your risk is going to go up a little bit. And so a lot of people do make that proactive choice, even in the absence of a gene mutation. It's a little more tricky to make that decision because there isn't a strong hereditary component to back that decision up, but that certainly should be a conversation that anybody with a family history could have with a doctor.
Could I weigh in?
Yeah.
Yeah, I just want to say too that when you were saying how the person who wrote in was saying that she was going to have or had the oophorectomy based on you know, her family history or the mutation. It wasn't clear to me. I just wanted to make sure that listeners know that, you know, sometimes I think there's this misperception that if you test positive, then you must then do X, Y, and Z, and that these surgeries are kind of, you're kind of committed to doing these extreme measures. And there are many, many ways to reduce your risk, with surgeries being kind of one end of the medical spectrum. But, you know, depending on where you are in your life, like my daughter, who's 24, is not going to run out and lop off her breasts and have a hysterectomy, right? She has available to her the fact that she can get on an oral birth control, because oral contraceptives can greatly reduce your risk of ovarian cancer. She qualifies for diagnostic breast MRI starting next year at age 25, which is above and beyond the normal protocol, and kind of heightened scrutiny with respect to both the breasts and the ovaries. And her medical team is aware of that, so that there are many measures that you can take with just kind of like, you know, heightened scrutiny, as I said, and diagnostic measures short of the surgeries. And so you shouldn't let, if the surgeries are not something that's appealing to you, let that be the barrier to having genetic testing. It's like, you do you, but whatever decision you make sure that it's a fully informed one using the full arsenal of information that's available to you.
Thank you for pointing that out, Katya. That's excellent information. I think we have one more question here. And that is advice on having screening after a hysterectomy. Should you go to your OBGYN or primary? Or should you, I mean, I would take a stab at this. I think if you have a family history, you obviously want to see a gynecologic oncologist, and not just your OBGYN, although that might be a place to start. So I'm going to answer that for her. And I think everything else is, thank you for sharing. Thank you for being there. Thank you for being honest. And so there's a lot of great thank yous out here. I don't see any other questions. Just one second. Wow, there's a lot of comments. So thank you everyone who's out there, who's watching. This is obviously a very important topic. And another person who commented about having RAD51C. A lot of yes, that happened to me. I think we're good. I think hopefully we have answered all of the questions. If we haven't, please know that we do go back and monitor the questions and answer them on the Facebook page themselves. You may not be able to answer, have Liz or Yvette or Katya or me or even Brenna answer that, but we will monitor that. And again, it does live on our Facebook page and our YouTube. So thank you. This was incredibly helpful. I hope for anybody who's out there who is watching to learn a little bit, understand that you're not alone, see the similarities we all experience, and just generally be aware of your, what you need to speak up for on behalf of yourself. So thank you all.
Thank you so much.